Over the last 13 years or so, the Andean Medical Mission has been working hard in northern Bolivia to try and eliminate blindness. A lot of the work that we do is based on identifying people who are blind with cataract or are in danger of going blind from large pterygium and removing those surgically. During these trips, we regularly identify patients with glaucoma, and sometimes we're fortunate and we catch the disease early and we're able to help people to not go blind from glaucoma. And there are times, of course, when we catch it a little bit late and the damage is already done. Today I want to talk about glaucoma and how to manage glaucoma in a setting like northern Bolivia, where we have 500,000 people living isolated lives well away from ophthalmology services, with poor communications, poor distribution of medicines. How can we help those people? Let's talk about it. The Oxford Handbook describes glaucoma as an optic neuropathy with changes to the optic nerve head. And the only treatment known to work in glaucoma is to try and reduce the pressure within the eye and preserve the visual field. Damage from primary open-angle glaucoma is not reversible. The only thing that you can do in glaucoma is identify the patient early, get them into a screening program, and if they have glaucoma, get them onto some sort of pressure-lowering therapy. There are a number of options available for the treatment of glaucoma. The easiest and safest is always an eye drop, and there are a number of different drops that can be combined to reduce pressure in the eye. But these rely on good pharmacy networks, availability of drugs, and patients, of course, complying with those drugs. There are also surgical options. There are a number of things that you can do to try and reduce the pressure in the eye. Most of those options, however, depend on good follow-up. Risk factors for open-angle glaucoma are generally high pressure, so pressure of above 24 millimeters of mercury in the eye. A thin cornea is also a risk factor, so less than 550 microns of thickness. Age above 60, and if a member of your family has glaucoma, then you are 10 times more likely to have glaucoma yourself. Hispanic origin is also a risk factor, which is very applicable to our population in Bolivia. Rupert Bourne, consultant ophthalmologist from the United Kingdom, wrote in 2019 in the Latin Guide to Glaucoma, wrote, "Why do people still go blind from glaucoma in Latin America?" And his conclusions were the following. 1/3 of the population are not diagnosed, 1/3 are not treated properly, and 1/3 are not compliant with treatment. Juan Carlos Silva, regional health advisor to the WHO, writing an article in 2020 about why patients are still going blind from glaucoma in Latin America, concludes the following. People are living longer, so there's a greater life expectancy now in Latin America. Up to 75% of glaucoma, in his opinion, is undiagnosed. There are low rates of adherence to topical medicines. There is a low level of knowledge about the disease. There's very limited access to diagnosis and treatment. So what is the solution for an isolated population of about 500,000 people living in small villages from 100 to maybe 3,000 population each village? How do you get those patients to understand the importance of glaucoma? How do you diagnose glaucoma in that population? And how do you provide an effective treatment, allowing for the fact that there is poor distribution of medicines, there is no access to year-round surgical options? The incidence of glaucoma worldwide is about 1.5%. The population of Beni, northern Bolivia, being 500,000, allows us to believe that maybe as many as 7,500 people are at risk of primary open-angle glaucoma in northern Bolivia. Medicines to reduce the pressure within the eye do exist in Bolivia. We have latanoprost, we have timolol, we have dorzolamide, and we have brimonidine. But they're quite expensive, and when you combine them for patients in the later stages of their diseases, you may need as many as 3 or 4 bottles every single month to actually get a benefit and get your pressure down to what your ophthalmologist has targeted your pressure should be? Well, that's expensive, and a lot of patients will start treatment, pursue it for a few months, and then give up. And just literally because they don't see a benefit and the cost is high, they feel that perhaps the medicines are not working, and they stop. So what are the solutions to glaucoma in an area like the Beni? Well, we've looked at medicines as a solution, and because of the poor distribution of medicines, that may be not a very good option. Surgically, we don't have anybody in northern Bolivia who can perform glaucoma surgery, and we don't have anybody who can perform the routine follow-up for glaucoma either. So surgery is not a great option. But there is an option using laser, and there are two lasers which potentially could be used in the population such as we have in northern Bolivia. The first option is sub-threshold diode laser, which the ophthalmologist can use to destroy a little bit of the ciliary processes which create or which produce aqueous, which ultimately creates the pressure in the eye. But in glaucoma, we have too high a pressure, so we want to reduce that. The second option is to create a number of small holes in the trabecular meshwork which let fluid out. And that can be done with an SLT laser. Both of those processes can be combined, and both of those procedures can be repeated. So they are a viable option for an area like northern Bolivia. The benefits, of course, are that you don't need monthly intervention. It's free because you just perform the surgery and then the patient can go to their home. It's repeatable, so if you see the patient again in the future and the pressure has crept up, you can repeat the procedure. And of course, from a compliance point of view, they're perfect because there's nothing for the patient to do. They don't rely on a supply of medicines, and they don't have to be compliant to anything. If you're more targeted and you screen patients who have a family history of glaucoma, and you treat or you screen patients that are over 60 years of age, then that has been shown to be far more effective. Carlos Reda, an ophthalmologist working in Latin America, published a study at ARVO in 2017 where he did a much more specific type of glaucoma screening. In this case study, 7,400 patients were screened by healthcare workers. They were screened over a 4-month period. The patients were all over 60 or had a family member who had glaucoma. So of those 7,400 patients, ultimately about 800 people were identified as being primary open-angle glaucoma suspects, and of those, half were ultimately diagnosed as having glaucoma. The cost of screening patients for glaucoma is very low indeed. You need some anesthetic, and you need some covers for your tonopen if that's what you're using. So the cost is probably about £1 per patient for the actual screening. If you're going to review 8,000 patients over a 4-month period, well, you've got maybe some wages to pay, but you could probably do all of that for around about £10,000. And if you can identify 400 people with glaucoma from such an activity, well, then that's a very cost-effective way of reducing blindness when compared to something like cataract surgery. So I think, in summary, NGOs should look at glaucoma as something that they can get involved in. It can be managed. You need a lot of public awareness. You need to get towns on board. You need to get the Ministry of Health on board, and you need to have some screeners in place to be able to measure pressure and to take photographs of the back of the eye. That can be done on a smartphone. It is possible to take photographs on the back of the eye with a 20 diopter lens and a smartphone, so you don't have to invest in hugely expensive fundus cameras like have been used in the UK for many years. I think, in summary, NGOs should consider glaucoma as something that is possible to work with. It should be something that we can put in place, or actions can be put in place alongside our cataract, pterygium and skin tumour work. I would encourage you to think about it as a subject and see if you can get more involved in reducing blindness from glaucoma. So that's it. I hope that was useful, and look forward to speaking with you on the next topic. Thank you.